Well, welcome everyone, and I'm happy to be here. I wanted to run through some HIV clinical pearls, just kind of the first of the series, so to kind of get the basics down so we could get kind of more intricate as the year goes on, so welcome. I wanted to go over a couple objectives today. Why are ART generics so important? A lot of times in clinic and in patients, I'm hearing a lot of brand names, and I know we kind of learn brand names and we go to drug talks and I hear brand names, but sometimes it's really helpful to train yourself to learn the generic first, and I'll go into why that's important. Managing HIV and renal insufficiency, a lot of our outpatients have bumps, if you will, in their creatinine, and there's been a lot of questions of what do we do, what ARTs should we choose, how do we manage that? Second one is a lot of viral load increases. So viral loads, we expect some bumps in viral loads, but what to do and when to get a genotype. Vaccinations, which vaccinations are actually appropriate besides the standard one if one of your patients is traveling. And then managing transgendered patient hormones. So this is not really taught in standard medical school curriculums. And I wanted to go over this because sometimes what happens is you'll see a patient who's transferred to you already on hormone therapy, and it's a good idea how to know how to manage it. And how to approach the incarcerated patients. Patients with HIV have, unfortunately, a higher proportion of being incarcerated either in the past or in the future. So just a couple of tips on that. And then making referrals. So I want to always encourage you, when in doubt, refer. But I'm going to go over things that you can do on your own and then when to refer. And then when it's really important to get prior records, especially with a TB history. So why use ART generics? Brand names are catchy, they're fun, they're easy to remember. Well, first of all, the ID board exam only uses generics, so you're going to have to know how to think in generics. So if you learn the brand names, you're going to be at loss when it comes from the board exam, and it's really difficult to learn your mechanisms. So when you're learning ART meds, the generics will help you understand the mechanism of action, and that's going to help you choose a better regimen for your patients. Also, consistency in your notes and records. Those of you who work with us in the health department know that it is unbelievably complicated. There's actually a brand name and a generic name, sometimes together, and sometimes not even consistent. So it becomes very confusing when you use both brand and generic names in your notes and in your records. And I would say use generics, use them often, use them only. Scientific rigor, so the journals that you read are only going to use generics except for those very flashy ads, but otherwise you're going to be using generics. So please use generics. When you present to me, please use generics because that's really the best way to learn HIV medicine. ART mechanisms, I know you guys know this from prior lectures, but I wanted to go over this because it's helpful. The entry inhibitors we don't use that much. That's like Fusion or enfuratide is the generic. So enfuratide would be what you would look for that. I know you guys are familiar with NRTIs and NNRTIs, but what I wanted to point out for your board exams is that your NNRTIs are attaching the HIV enzyme, not just a building block. So you're going to have typically more side effects, especially with efavirenz in your NNRTIs. So just kind of remember that as well. And your protease inhibitors are specific to the protease enzyme, and then the integrase inhibitors, of course, are inhibiting the integration of the DNA into the cell. I wanted to go over this, and it's a really handy way. This was presented to me up in Connecticut, and I wanted to pass it along. I give credit to Dr. Michael Verrata up at Yale who came up with this, and this is a wonderful way to remember. So you have your tenofovir and emtricitabine. You can see the generic and the three-letter code. You'll see that in a lot of the ID conferences and a lot of the literature in HIV, so it's really important to learn those together. I put the brand names in parentheses, hopefully those becoming less and less prominent in your mind. Truvada is together. So when you go abacavir, lamivudine, those together give you Epsicom, which is a brand name, but I'm putting it in there so you know what to do. Zidovudine and lamivudine together give you Combivir. And then if you have the three of them, you get Trizavir. Obviously, we don't really prescribe Trizavir anymore, but you'll see the patient usually sometimes transfer to you on it. Didanosine and stavudine are really just historic relics, but just know them because the boards likes to talk about them sometimes. NNRTIs, efavirenz is our favorite. Together, they get a tripla. Rilpivirine is also very nice. It's a very small pill, and together they have Complira. Remember, Complira, you need to have a viral load less than 100,000 when you start. Etravirine and nevirapine. Integrase inhibitors, again, a good way to learn generics. It's all a vir, usually at the end. Maltegravir, dolutegravir, and elvitegravir. As you know, elvitegravir is only available in the combination, brand name Stribold, or Stribold, but PIs. Now this I want to go over just so people understand. The bold-faced ones are ones you can give once a day, so that way it'll help you kind of select things for your patients. Darunavir you do give with ritonavir. Atazanavir you can give with or without ritonavir depending on your prior resistance or prior history. Fosamprenavir, again, with or without ritonavir. So this is kind of neat because technically you could give atazanavir once a day without a booster, so that's possible. And remember, leponavir does contain ritonavir, the brand name Kaletra. So these are, again, historical relics. Those are the old PIs. We don't really use them anymore. And I don't even think they're on the boards anymore, but just so you know if someone mentioned them. Your CCR5 antagonist, Maraviroc, dosing depending on your other antiretrovirals, and fusion inhibitors, which I have not seen used, but that would be really last resort. So moving on, HIV and renal insufficiency. So you have an HIV patient, this comes up a lot in clinic. They have a bump in creatinine. What do? Kind of think to yourself what you would do. Some people want to stop the ART and kind of, let the smoke clear. Some people, just want to adjust the ART. And it's actually a combination of everything. We never want to stop the ART. A lot of our patients are already on a diuretic, and we've been noticing that this is actually the biggest culprit is hydrochlorothiazide. Usually when you stop the hydrochlorothiazide, they'll be fine, especially in the summer. And I really do want to encourage you to look for drug-drug interactions. Some of these people are on high doses naproxen, and there's a lot of things that you can do just to investigate a little bit why this is happening. And I'm going to talk, and definitely please call the primary care, especially if you think hydrochlorothiazide is the culprit, and you guys are doing a great job on that, but just keep it up, that's great. Adjusting ART, so I wanted to continue with that. So usually what we see is a creatinine clearance dropping between 30 to 49, so just below 50. I wanted to give this very neat kind of way of remembering what to do. So Truvada, you can actually just bump it up to Q48 hours in creatinine clearance 30 to 49. Abacavir is no change. Lamivudine you change daily, so usually it's 150 BID, you just change it to 150 daily. And then Zidovudine there's no change. And this actually is a board question in the practice boards. Zidovudine, you don't change until your creatinine clearance goes less than 15. You still can't give Combivir or a triplet because of the chemicals that make it up. And NRTIs, you don't change. So you can still, if someone's on a triplet, you can just give them Truvada every other day, plus your efavirenz at a steady dose. You can also give them rilpivirine, which is great. PIs, no change, which is great. Integrase inhibitors, not really a change. Now, dolutegravir is a little bit if you get worse renal function, but if your creatinine clearance stays above 30, you're in pretty good shape. So, looking at it, it's really just kind of your lamivudine and your tenofovir emtricitabine. All the other ones are pretty good. Granted, when you get to hemodialysis, that's a whole other way of dosing. But for what we see in clinic, it's pretty easy to kind of remember which ones change and which don't change. So hopefully that'll help. I want to talk about 184V mutation. We've been seeing a lot of these in clinic. As you remember, pathway confers resistance to abacavir, emtricitabine, and lamivudine, but that same pathway actually increases your viral susceptibility to tenofovir and AZT. So basically, Truvada, TDF-FTC, tenofovir, emtricitabine is not ideal. We used to do that in the past, but because of the emtricitabine, it's not ideal. The new thinking, yeah, we see this a lot in the clinic. Tenofovir, emtricitabine, a boosted PI, and riltegravir, which is kind of bulky. So I'd like to recommend, if choices are if they don't have chronic Hep B, obviously if they have chronic Hep B, keep them on the TDF-FTC. But the tenofovir or AZT is really a better choice. It's a cleaner choice, plus an NRTI. And you can certainly have an integrase inhibitor or a boosted PI, but may not be the best thing just to continue that emtricitabine if you know you have resistance. I haven't seen any problems with it, but it's cleaner to try to take them off of it. And again, it's kind of a practice-based preference, but just keep that in the back of your mind if you have other alternatives. And this is a patient that we saw recently that was doing very well in this regimen. And it's a very clean regimen. He did very well. Everyone will be different, but I just want to let you know that tenofovir by itself is effective, and this was a very effective regimen. So HIV viral load, let's assume that your patient is compliant. It's not just a compliance problem, and they have a viral load increase to about 300, 400 copies, 800 copies. What do? Do you just kind of order a genotype? Do you check drug-drug interactions? Do you really doubt that they're compliant and you give them another lecture? Or do you inquire the time of day the medication is taken? So kind of think to yourself, but I would recommend, genotypes are very difficult to obtain unless your viral load is greater than 2,000. I've seen it maybe 1,500, 2,000, but sometimes it's not very helpful, especially 300, 400, 500. A lot of the time there are drug-drug interactions, so I want to encourage you. I know it's kind of a trouble to do, especially if there's a busy clinic, but I can't tell you how many times I've seen interactions with psychiatric meds or meds they forgot to tell you about or something like that, and that usually solves the problem. I had a very interesting case in actually the New Haven prison of all places, but I was on fosproprenavir and 2 psych medicines, and they had been started after he had seen us, and he came back, his viral load was around 1,000, 1,500, we couldn't figure it out. I actually had to go through all of his 15 meds, and sure enough there was a drug-drug interaction, so we had to change his psych meds over and adjust, but it was really good we did that, because that was the problem. So also time of day. Some medicines are more robust than others, but I would just talk to your patients and make sure that they take it. Try the same time each day. So don't be shy. We have a lot of pill boxes in the health department, and I want to tell you about the Care for Today app for medication reminders. So the Care for Today has, it's actually just launched by Janssen Pharmaceuticals. It's pretty helpful. I downloaded it and tested it just for kicks. It works pretty well. It'll give you the medicine, what the medicine looks like, and it will actually give you phone reminders when the medicine needs to be taken. Very helpful, and it actually gives a compliance report at the end. And it's neat because you can actually link it to either children or parents or partners or spouses, and you can kind of see what people are doing, and you can actually get reminders for, I think, another family member. So pretty neat app, and might be helpful to your folks who are more tech savvy who might need help remembering. Vaccination pearls. So I know you guys always know that we talk about vaccinations, but I just want to make sure for those out there in Podland, it's only when your CD4 count is above 200. We've seen a lot of cases where people are getting Hep A and vaccines when their CD4 count is 30 or 40, and it's not going to work very well because their immune system just can't handle the antibody production. We know the standards, but what about travel? We had a recent case of a guy going to the Caribbean. So basically, typhoid IM is fine, not oral. And then if they hadn't been boosted or they have not had the polio vaccine for some reason, usually most people will, but inactive polio vaccine is fine, not the oral. Consider meningococcal vaccine for high-risk MSM. Those in dormitories, military service, etc. There are outbreaks in New York City, so just consider that. And then live vaccine, we used to be taught that you don't give MMR vaccine or varicella zoster, but I was looking into it, and it looks like they've changed their recommendations that if the CD4 count is above 200, it is possible if there's no prior immunity. But thankfully in the US, a lot of people have already been vaccinated through their school programs. And these are the contraindicated vaccines. So pneumonia vaccine, I just wanted to, kind of the latest is that both the 23 and 13 valents are recommended now, and the dosing depends on your immune history. So if someone's had prior 23 valent, the recommendation is that you give them the 13 valent 1 to 2 years after last vaccine. And for naive patients, you give the 13 first, and then the 23 valent 8 weeks following. As we know, it's a booster every 5 years. I tried to find the sequence, like once you've given the 13 and 23, how often do you give it again? I don't see any clear recommendations out there that I've seen, but it seems to reason that you would boost in immunocompromised. I would just do 1, but I don't see the full guidelines. I don't think anybody knows quite yet. And then in Florida, thank goodness we have the Florida shots, so we're entering all those in. But if you're working outside of the health department, usually, hopefully, you can find some information there. But if not, if you're working in an office somewhere, make sure that your office enters it into Florida shots. Transgendered medicine, there was a lot of questions that came up. So I wanted to go over this briefly. So let's say someone's transferred you or wants to start hormone therapy, and what do you do? Some people, some HIV providers say, I don't know how to do it, I don't want to do it, it's not my job. But I think the kind of the forward thinking is to say, all right, this is part of HIV care, either referral, but also the guidelines are very easy, and I just wanted to go over them with you because I think you'll find it's easy to manage it yourself. This is a very, very good resource. This is from your HIV guidelines, which are the official guidelines, the Department of Health and Human Services. This is a sub-reference, if you will, put together by the New York State Department of Health. And I just wanted to go over the terms. Basically, transgendered, remember, it's an umbrella term, so it's a general term for gender identity. So it can include any transgendered individuals and any kind of bisexual or bigendered individuals. In our clinics, we mostly see male to female transgendered individuals, but female to male also. And it's very interesting, actually, the science behind it. I looked into this because I was trying to understand it, and it looks like that it actually is, there's a genetic component to this, like parts of the brain are developed or undeveloped, and that's how people actually think about different kinds of ways of gender. So it's very interesting, and we're still learning more about it, but certainly it's important in HIV care to understand and be savvy about it. So key point, basically the difference between sexual orientation and gender identity, and there's a lot of variations. So always good to ask, very open questions in terms of sexuality. Do you have sexual intercourse with men, women, or both? How do you identify yourself? That kind of thing. So just in terms of hormone replacement, this is actually very important medically. I've had a lot of patients transferred to me on way too much estrogen, and that can actually be harmful because it can be, because you can imagine, right? Remember the hormone replacement therapy problems with heart problems and breast cancer, et cetera? Well, it can be the same in men, actually, who get too much estrogen. So just please check to see if your patient's on the right dose. But you can see the doses there. Usually there's an estradiol shot every 2 weeks. That's usually the easiest, up 5 up to 30, and then we'll talk about the goal labs in the next slide. And then usually you do the injection estradiol plus the spironolactone. It also helps if they're hypertensive, but always watch their electrolytes, at least in the early part. And you can choose between 100 and 200. Those are the main things that we see, and then some people will also take oral estrogen as well. Laboratory monitoring, so basically these should be taken at least every year, but if you have a new patient transferred to you, I'd suggest taking it right away. The estradiol levels should be 100 to 200, and the serum testosterone levels should be suppressed. So it makes sense intuitively, but also remember that routine cancer screening is really important, and actually mammograms for men who have a lot of breast tissue. So just make sure that you're up to date on that. So HIV in prison, we have this interesting thing in our clinic about a mental health check every year. And I was talking to someone, and they're saying, yeah, he's doing fine mentally, but he was in prison and he was, beating his wife. And I was like, no, that's not good. So obviously, just consider recent incarceration as a very troubled mental status evaluation. So even though they might look at you and say they're fine, obviously, if someone's been incarcerated, you need to either probe yourself or figure out what's going on and if they need to be referred. Remember that medical benefits can be suspended in jail and prison settings, so they're probably going to need a lot more social work to get them back on track, and sometimes housing situations can be troublesome. I would recommend rechecking for STIs and hepatitis and release. A lot of prison systems already check for tuberculosis on entry to prisons and jails, but always good to make sure they're up to date. And then they definitely probably need additional social support, because a lot of people who are in prison unfortunately go back to prison because they don't get their primary problem solved, which usually is a mental illness. So I always recommend counseling. Referrals. I want to give kudos to Nancy, who is our resident renal renal doctor here. You guys are doing great. You guys are really doing great in terms of renal insufficiency, electrolyte imbalances, thyroid problems. You guys are doing great with. So I want to encourage you to do as much as you can within the lab confines that we have, because there's a lot that we can do in the clinic and ourselves. And you guys are doing a great job. But I just wanted to also say, if you're kind of at the end of your rope with these, I would go ahead and refer out. I know it seems intuitive, but just take the time to do out the form, and I think you'll find that it works. Also, there are pamphlets and apps and information packets, and I'm going to try myself to get more pamphlets and apps available for the clinic, but they actually have really neat patient information sections on diet and nutrition, so I'm going to see what I can do in terms of getting more pamphlets available for patients. Records, I want to talk a little bit about latent TB. One of the things with HIV patients, as you know, they're very, very susceptible to reactivating TB, and I know it's very hard with our record system to figure out exactly what therapy they've had and what they're doing. But I would really encourage you to try to get to the bottom of it and document it in HMS, because once you know the information, you know it. Otherwise, you and other providers are going to be guessing for each visit, and it's very difficult and it's very dangerous for the patient, because you could have recurrent active TB and you're not following it up. So again, usually 9 months of isoniazid plus B12 for latent TB, and just make sure that we get to the bottom of it. Also, OIs are very helpful, but I would encourage you, because patients change hands every 2 years, that just document what OIs they've had and what they've completed and how long they've had their prophylaxis, because otherwise, again, it's a guessing game in terms of what they've had and what they're doing. So I would definitely put it in their medical history. There's actually a section there. It'd be very helpful. And believe me, it'd be easier to see your patients once you have everything there. And I just want to encourage you, if you haven't had Lab Tracker, please talk to Steve and get it. We're able to get that for you guys, and super helpful, as you know, and it's a lot easier than the paper chart. So I just want to encourage you to become empowered and use Lab Tracker so you can figure out exactly what everybody has and what vaccines they need, because it's very helpful.